Welcome to all the PhysioTV viewers. Today we have with us Dr. Ira Indurkar. Ma'am has completed her Masters in Neurosciences from KEM. She is currently working as an Associate Professor in Datta Mege College of Physiotherapy. She's also an NDT practitioner and has completed her NDTA TMR TOS Level 3 from USA. We are happy to have you, ma'am, on board. Handing over the session now to you.
So the topic today we are going to discuss is early intervention assessment of children from birth to 3 years, and the part one would be assessment of children who are premature. So we are going to see in part one that how we identify the risk of having a developmental delay and how to screen children with the developmental delay and how to start intervention when they are premature. Next slide please. So that's what we discussed, identify potential risk in premature infants and assessment for early intervention services. So to begin with, what is early intervention? Early intervention is an umbrella term which encompasses a range of different supports to promote optimal child development, such as interventions targeted to improve child and or family outcomes in general, and to provide them with support systems so that they reach their maximum potential. Next slide, please. So domains in early intervention are motor. So some children who have motor issues, you can start early intervention. Some children might have some cognitive issues and you can do early intervention. Some children might have hearing and communication disorders and you have to start early intervention. Some children might have social, behavioral and adaptive skills dysfunction and then you have to start early intervention. So early intervention for children, mostly we have these domains: motor, cognitive, communication, social, emotional and adaptive skills, and all of the domains can also be involved in the same child, or then you can have one particular domain which is involved and then you have to do domain specific screening and then domain specific intervention. Next. So the question here is, do we really need definite diagnosis for early intervention referral? So a lot of times people think that the child is not yet diagnosed with anything and how to start early intervention, but that is not the case. So you as a therapist, like this talk is basically for physiotherapy intervention. So as a therapist, we all can start early intervention as soon as we see the child, and if we assess him and see a potential risk or if we see a definite delay, then we have to start early intervention immediately. We do not wait for the diagnosis. So the diagnosis can come. You also start the process of getting the child diagnosed, doing appropriate referrals, working in team. All that is needed, but you should not wait for the child to be diagnosed with condition before you start early intervention. So today's talk is mostly focused on identifying the potential risk for developmental delay and you intervene early so that there will not be any disability, or you can minimize the complications, and you uh, kind of help the child develop to his optimal potential as soon as you see the child with risk. Next. So the how the cycle is going to work is you're going to recognize the potential need, then you can identify and you can diagnose, and then you start early intervention. But you can start the process of recognition potential needs, start early intervention, and then go for identification and diagnosis. So that can also be done. So it's not a linear process. It's kind of a parallel processing. As soon as you recognize the need for intervention, you immediately start. And meanwhile, you also set channels for further assessment and diagnosis for the child to have a definite medical condition. Next. So neonatal screening. So in neonatal screening, when you're working in the NICU, the early intervention should ideally start in NICU. So what you have to do in NICU, you have to establish the risk in the NICU children. You establish the risk in the children who are born preterm. You establish the risk in children who are born at term. So all these children, either they are premature and in NICU, or they are full born and in NICU due to different medical conditions. So you have to identify the potential risk for having developmental delay or neurodevelopmental issues in them, and you have to start early intervention right in the neonatal ICU. So then we are going to see how the preterm infant looks and what all other signs you're going to see and how to identify the risk in preterm infants. So next, please. So the early intervention team can be a full-on team with neonatologist, clinical psychologist, early interventionist, physiotherapist, occupational therapist, neurophysiologist, speech therapist, nutritional, and medical social worker. So in certain setups, which are kind of, in urban area and where all the infrastructures and resources are available, all the team can be present in the NICU. But in low resource areas where, like as in our country, in low income countries, we do not have fully functional early intervention team in many of the ICUs. So you might have a physiotherapist and an occupational therapist. So you have to just start with whatever is available. So a neonatologist, a pediatrician, a physiotherapist, and an occupational therapist can form a team. If you do not have even occupational therapist, a neonatologist, pediatrician, and physiotherapist can be a team. You need to have a good collaboration, and you have to identify the children with potential risk and start early intervention as soon as possible. Next slide, please. So assigning the risk of neurodevelopmental disability based on perinatal risk factors. So we all have been studying about the factors which can cause neurodevelopmental delays. So further, we can, categorize those factors into children with mild risk, children with moderate risk, and children with severe risk. So who all are the children who are in the mild risk? So if the prematurity or the birth, like gestational age is between 30 to 34 weeks, they would be at mild risk just by the, there are a number of factors. Like you have to take into account gestation, you have to take into account the birth weight, then if there's any episode or event which has happened in NICU. So all the factors combined will stratify them either into mild, moderate, or severe category. So when we look at the child with mild risk of neurodevelopmental disability, so they would usually be born between 34 to 36 weeks if they have birth weight of 1500 to 2000 grams, or if there is a hypoxic encephalopathic event which is only grade 1, and if there's a hypoglycemia which is the glucose value of less than 50 after day 3 and less than 40 between the day 1 and 2, if their bilirubin levels are more than 20 milligram per dl, if there is a sepsis which can be treated with IV antibiotics, and if there's an episode of scissors, only one episode of scissors with hypocalcemia, then all these children are at mild risk. But the children who are born between 29 to 33 weeks, the children who have very low birth weight, that is between 1000 to 1500, and if the hypoxic encephalopathy episode is grade 2 level, then all those children are at moderate risk of having neurodevelopmental disorders. And the children who are at severe risk, they are usually very preterm, that is born less than 28 weeks of gestation and having the birth weight which is less than 1000, and hypoxic and ischemic encephalopathy of grade 3 or more. Then, if the scissors is associated with apnea, if there are persistent jitters, if there is encephalopathy or kernicterus, so one has to have bilirubin level which are more than 22 milligram per dl to call it kernicterus. So all those signs will tell you that whether the child is having a mild risk of having a delay, moderate risk, or severe risk of having a delay. There are certain other things which also you have to look at. Next slide. Like ventilation. So somebody who needed oxygen or CPAP is not having a great risk, but somebody who needed an invasive ventilation, they are at a moderate risk of having a delay. And somebody who had severe respiratory dysfunction and needed respiratory support for more than 28 days or invasive ventilation for more than 7 days, then you would need, they would classify into a severe risk of developmental delay. So when you take the history or when you gather the information from the parents, all this becomes very crucial in knowing whether the child was having ventilation, which was more than 28 days, ventilation for more than 7 days. Then, if he needed just oxygen or CPAP, so all this information is very important to gather from parents to risk stratification of children, whether they come into mild risk of developmental delay, moderate, or severe. Because after the risk stratification, you're gonna decide whether to conduct a full screening and put them on intervention, or you just want to put them on follow up and see how they develop eventually. So this decision lies on all these factors. uh, the place of birth, the antenatal care, if they have received or not, whether they were twins births, whether there was any previous stillbirth history. So all the history taking which we do, and all the assessment which we are doing, all these factors are very important. And after gathering all this information, if you are a therapist who are working in the NICU, you readily have the access to all this information. If you are seeing child outside the NICU after discharge, then you should gather all this information to do appropriate risk stratification. So some children might have neuroimaging and some children might not. So if they have neuroimaging done, then well and good. If not, you can suggest neuroimaging depending upon the factors. If they come into the severe category, then you have to ask them for go for neuroimaging and go for pediatrician, like neuropediatrician's referral, and start early intervention accordingly. So these are all the factors you have to consider. Next. So assigning the level of care. So now you've assessed according to the history and according to the investigations and the file you've seen in an ICU. You have to now decide what the plan of care or level of care you are going to assign the child. So children who are at low risk, you kind of ask them for come to follow up and get screened at regular intervals. We'll talk about what regular intervals mean in a few slides further. Then children, you start early intervention stimulation. You'll not do intervention, but you'll start stimulation. So you'll tell the parents that you have to position the child, you have to play with the child, you have to actively engage, give sensory stimulation, interact with the children, talk more, give them exposure to different kind of textures. All that you can tell the children who are at low risk, and you can call them for follow up. With children who are at moderate risk, you have to screen and start early intervention. The responsibility lies on pediatrician to refer the child to you if you are not in the team already. And then you do not wait for the child to get the diagnosis. You start early intervention immediately for the children with moderate risk. You can do at developmental unit if you have one, or you can start in your OPD, or you can start even at home. Then children with high risk, you need to have them get diagnosed if they have CP, if they are any metabolic conditions, if they have any genetic disorders. So you have to get them diagnosed, and then you have to start specific intervention if they have hearing issues, if they have visual issues in addition to motor delays. So you have to get them diagnosed and have them to start specific intervention. And in like this children who have severe issues, they can have retinopathy of prematurity, they can have hearing deficit, sensory neural hearing loss. So they will need a rehabilitation team for them to reach their optimal potential. So the early you start, the better outcomes you're gonna get. Next. So like we saw, early intervention will be first you'll do developmental screening. Then if you find that there's some delay, like some motor delay, some sensory issues, or communication issues, or hearing vision issues, or feeding issues, then you do domain specific evaluation and assessment. So if there are motor delays, you would be the person who would be doing screening. If there are some sensory issues, you would want an occupational therapist on board. If there are some hearing and vision issues, then you would want them to be on board. And then you'll start domain specific intervention. So next slide, please. So this we have already discussed. So early stimulation and home program for children with mild risk, early intervention, domain specific intervention for children with moderate risk, and specific therapies and diagnosis has to be started for children with high risk. Next. Now here comes the part of examination of infants for motor function of children with infants. So as a therapist, even if the child is born premature, so prematurity is anything below 37 weeks of gestation. So they can be between 28, like after 28 weeks of gestation or before 28 weeks of gestation. So if they are before 28 weeks of gestation, they are very preterm. If they are between 28 to 32, they are preterm. And 32 to 37, they are just preterm. So before 37 weeks, we call them premature. So in those children, you're going to examine the tone, posture, movement, reflexes, sensation, behavior, and you're going to use some standardized outcome measure. So now the tone can be hypertonia in children or they can be hypotonic. As you see from birth to 1 year, the same is the case with prematurity also. They can have hypotonia or hypertonia. They can show some postural changes. So they can show some tonic changes in the posture. Their movement can also be affected. The reflexes, we're going to see in the next slide what all things we are going to see. So the next slide, please. Okay, so we are going to check their mobility in supine. You're going to check their neck reactions in supine. You have to check their eye muscle control, head position in prone and supine, upper extremity position in prone and supine. You have to see if there are any locomotion and transition, not per se, but upper extremity movements. You can see frequency and variety of movements are very important. So fetal movement starts at 14 weeks of gestation. So from 14 weeks to 28 weeks, 32 weeks, you will get some movements which are well defined. There is a variety and there is those movements are smooth and synchronous. So all those things we can look at when we are looking at a child who is premature. Then you're going to see visual following and you're also going to see some neonatal reflexes. Not all the neonatal reflexes are present in children who are born premature, but some of them are present. So we're going to discuss what all you can see and how they are different from the birth, the child who is born full term. Next slide. Okay. So when you when you look at a child who is born preterm, uh, there's going to be a certain difference between a preterm child and a full term born child. So first sign when you see the posture is scarf sign. In scarf sign, what you do is you passively flex the arm across the body. And when you're flexing the arm across the body, you see whether there is any resistance or not and how far the elbow goes. So normally, if the child is preterm, then he will not have any resistance and the elbow should go to the midline of your body. So the elbow will pass the midline or stay at the midline. So that is normal. If you see the term infant will show some resistance to movement because there's a physiological flexion which is going to happen in a term child, and the preterm child will not have physiological flexion, and that's why the arm is going to go till midline, like the elbow is going to go till the midline. But for the preterm child with hypotonia, the elbow is going to almost the opposite shoulder. So if they go further and if the child is very floppy and low tone, the elbow in the scarf sign is going to decide that how much the hypotonia the child has. So this is one of the important signs to look at when you are assessing a child with prematurity. Then the next is the popliteal angle. So popliteal angle is the angle between the femur and the leg. So you extend, basically it's the hamstring tightness which you're calculating. So when you passively move the knee to the chest, the angle for the premature child is between 135 to 180. So if the child, and at term it decreases. So at term it is anywhere between 60 to 90. So when you are looking at a premature child and if you see that the angle, popliteal angle is less than 60, then you say that the child has hypertonia because then the hamstrings would be spastic and tight and the knee extension will not be full. So this is one of the important measures to distinguish whether the child has hypotonia or hypertonia. That is the popliteal angle. Then you can also see the ankle dorsiflexion. So you move the ankle towards the shin. And if the angle is between 60 to 90 degree, that is normal for a preterm child. And if it is less than 30, then it is abnormal, because then the child has hypertonia in the gastrocnemius, and the length of the dorsiflexors, the range of the dorsiflexors would be limited. So this tells you that if the child has hypertonia or hypotonia, so it's important to see the scarf sign, the popliteal angle, and the ankle dorsiflexion, that is foot to shin. Then there's another test you do that is called a slip through. So you hold the infant in vertical position, holding under axilla. So if the child is premature, he will or she will slip through that position. If the child is at term, then he will anchor the shoulders and will not be able to slip. So those are the signs you're gonna see. Then you can also see pull to sit. So in pull to sit sign, there would be a profound head lag for a preterm child, and the head lag will not be there in the term child. So pull to sit is also one of the tests you can see. Then rooting, sucking, and grasp reflex are absent. Sucking is weak. It is present, but it is weak in preterm child. Rooting and grasp are absent. So these reflexes will not tell you much about the if the child has hypertonia or hypotonia. But the scarf sign, the popliteal angle, the movement which the child is performing, the rapid movement, or at when the child is just lying in supine, how is he moving his upper extremity and lower extremity? Whether there's a fluidity in the movement, whether there's a variability in the movement of both the extremities, and if the child is able to move in and out of certain positions. So that tells you a lot about the movement system in children who have prematurity. And the children, what are the profound signs of hypotonia in premature children is one of the scarf sign. The other is floppy limb and heads. Then poor muscle resistance. So when you try to move them, the resistance will be poor. The grip would be weak, and obviously they are going to show some delays. What would be the signs of hypertonia? So hypertonia, the scarf sign would be the child, you will not be able to take the elbow to even to the midline. Then the popliteal angle would be reduced. The angle dorsiflexion angle would also be reduced. And you will see that the child is kind of fixed in one posture and is not showing a lot of variability in the movements when it comes to upper extremity or the lower extremity movement. So all these signs kind of, lead you to pick up the children who are premature but not performing optimally. Next. Then there are certain outcome measures you can use. So the two most commonly used outcome measures are the general movement assessment and test of infant motor performance. So these are the two signs which can tell you, they can predict, and they can categorize the children having developmental delay when they are premature. So we're going to see what GMA does. Next slide. So GMA is General Movement Assessment. It is early identification of infants at risk of delay. So in GMA, what you do is you do video analysis of the child when he's awake and ready and moving, and then you in slow motion you take pictures of that video, like you take stills from that video, and then you compare and see how much movement are there, how movements are variable, whether there's lower limb movement, whether there's upper limb movement, whether it's flexion, whether it's extension, how much the child is moving throughout. Those stills you compare, and then you come up. Then they have a norm referenced already. So the scale has norm reference. That means that what a 32 weeks of premature child without having any complication should move, they have already standards for that. So they compare your video with those standards, and they come up with how much delay the child has. It is a very sensitive and specific test. It is valid and reliable. It can identify the risk of CP, even minor neurological deficits, if somebody would have or will have autism or cognitive impairment. And all this can be done. It is done from birth to 4 months. So whatever is your birth, even 28 weeks, 32 weeks, whichever prematurity, to corrected age of 20 weeks can be, the scale can be used. The scale requires training, so you have to get a formal training to use this scale. Next slide, please. So this is one of the pictures of this particular scale. You see in the first picture, that is A, there's a child who is in a physiological flexion. You can see both the lower limbs are nicely flexed. And now if you look at the left extremity, see the left shoulder is taking various positions in all each of the frames which they have taken. So it's going from full elevation to horizontal adduction to taking it to the mouth, then again extending it. So in every picture, you see the left shoulder is doing something different and moving a lot. Whereas if you see the B child, and if again you see the left shoulder, most of the time it is an extension and horizontal sorry, it is an abduction to 90-degree, and more or less it's almost abduction and elevation, and abduction and elevation. So you kind of see that the child B is not moving into variable positions. So that kind of tells you that child B has some issues which are related to movement system and posture system. So if you do a GMA assessment of this child, and if you quantify the age and you quantify the movement and the type of movement, you can actually get at what week the child is performing, how much delay there is, and whether the child is having any potential neurological risk on it. Next slide, please. Next is the TIM, that is the test of infant motor performance. This also needs some training. It is also norm referenced, so you can see what a normal 32 weeks child should be able to do and what your 32 weeks old child is doing. You can compare it and you can come up with a score which can tell you how much delay there is and what you can expect. This scale is also valid and reliable. It is specific and it sees the body alignment, selective motor control of fingers, anti-gravity limb movement. So all that can be tested. So once you can pick either of the outcome measures and then come to consensus apart from the observation and the examination testing which you have already done, whether the child has a risk of potential developmental delay or not. Next slide. So now you know that the infant is premature and is at potential risk. Premature in itself is not a risk, but all the factors which we have discussed can cause delays. And if there's a medical diagnosis like some child who has spina bifida, some child who has some genetic abnormality, so that medical diagnosis in itself we know can cause developmental delays like Down syndrome. So that those children can automatically qualify for early intervention. The children whose diagnosis is not sure, but now you know that they are at moderate risk or high risk, plus you have done some outcome measures and analysis, and now you know they are either hypertonic or hypotonic, and they have some scores which tells you that there is a delay. Then you now have established a potential risk, and now you will start early intervention in an ICU. And if the child is getting discharged, you're going to follow up that child at your high risk OPD. So what are the frequencies and durations of follow-up you're going to recommend? Next slide. So the very preterm infants, which are less than 32 weeks or less than 1500 grams, you're going to call them after 7 days of discharge to check if the infant has adjusted well in the home environment, and every 2 weeks until the child has sufficient weight gain. And at immunizations, which is like 1.5 months, 10 months, and 14 weeks. And after that, at 3 months, 6 months, 9 months, 12 months, 15 months, and also every infants with other conditions, you're going to call them 2 weeks after discharge, and at 6, 10, and 14 weeks of age, and at 6, 9, 12, 15, and 18 months of corrected age until 8 years of, then at 6 months interval until they turn 8. So these are the recommendations for follow-up from Indian Association of Pediatricians and best practice guidelines from American Physical Therapy Association. Next slide. Okay, so this is it for the part one. If you have any questions, I'm happy to answer.